In the next 10 minutes or so, I will try to talk to you about cardiac adaptation in female athletes. So we'll try to discuss the gender effect of cardiac adaptation to exercise, to define the limits of cardiac adaptation in athletes, to discuss the possible molecular basis of gender differences in cardiac adaptation to exercise, and we'll try to understand the epidemiology and causes of sudden cardiac death in male and female athletes. So in the last 30 years, many studies try to investigate cardiac adaptation in athletes, but the main studies, most of the studies, were focused on male athletes. However, we know that there is an increasing proportion of females involved in all types of sport, as it is summarized by this histogram, which represents the proportion of female engaged in the Olympic Games. We see that in the London Olympic Games in 2012, almost 50% were females. And there is no doubt that there are several differences between males and females, from molecular to hormonal to physical and psychological level. But what about cardiac adaptation? So this is one of the first and probably one of the largest series of studies on cardiac adaptation in women. And in this study, the authors investigated 600 female athletes. And they found two important things. The first, if we consider LV cavity dimension, we see that just 8% of female athletes showed increased LV and diastolic diameter. We know instead that male athletes may show increased LV cavity size in 30–40% of the cases. So this is the first point. The second important point, what about the left ventricular wall thickness? We see that none of the female athletes investigated in this study showed a wall thickness of more than 12 millimeters. While we know that male athletes, especially the ones of Afro-Caribbean origin, may exhibit a wall thickness between 13 and 15 millimeters. And okay, I know what you're thinking. So this study considered just absolute values for left ventricular cavity dimension, left ventricular wall thickness. And we know that men have larger body surface area. Well, most of the times. However, this is jokes apart. It can be very true because particular type of sport, females may be characterized by a very large body surface area. They may be particularly tall and muscular. So does size matter? In particular, does body size matter, and the relationship between body size and cardiac dimension? This is not just an academic question, because if we understand more about the relationship between body size and cardiac dimension, we would be able to more accurately differentiate physiological training adaptation from deadly conditions as cardiomyopathies, as dilated cardiomyopathy and hypertrophic cardiomyopathy. But what is the best way of scaling cardiac dimension? And there is a good degree of confusion out there because we don't really know what is the best way to scale cardiac dimension. Some say that the best way is to scale for body weight. Somebody else said that the best way is to scale for body height, even for allometric scaling, considering an exponent, or even for lean body size. So just considering the muscular weight. Big cardiac societies, as British Society of Echocardiography and European and American Society of Echocardiography, suggest to scale for body surface area, even if they acknowledge that this may be not the best and the most accurate way of index cardiac dimension. So in this recent study, we tried to go beyond, in some way, this concept of absolute left ventricular dimensions, and we tried to look at effect of sex and sporting discipline on left ventricular adaptation to exercise, looking at a specific parameter, which is left ventricular geometry. Left ventricular geometry is a parameter without a dimension, and it is basically, it relates from two main parameters, which are relative wall thickness and LV mass. And we can have four situations. We can have normal relative wall thickness and normal LV mass, and the left ventricular geometry is normal. Or we can have increased relative wall thickness and normal LV mass, so we have concentric remodeling. Or we can have increased relative wall thickness and increased LV mass, so we have eccentric hypertrophy. Or we can have increased relative wall thickness and increased LV mass, so we have concentric hypertrophy. So we analyzed more than 1,000 athletes, elite athletes, so more than 20 hours of exercise per week, and more than 40% were females. What did we find? So first of all, if we look at LV mass, according to the ASC guidelines, almost 1 in 4 athletes had an increased LV mass. Both males and females had 24% increased LV mass. And we know that ASC consider increased LV mass different threshold, different cutoff values for males and females, more than 115 grams per square meters in males, more than 95 grams per square meters in females. The second point, no females had LV mass of more than 145 grams per square meters. Third point, what about relative wall thickness? Less than 5 out of 1,000 males have a relative wall thickness of more than 0.5, and none of female athletes had a relative wall thickness more than 0.5. So this is important because it may help us in differentiating physiology from pathology. So we found that the majority of athletes had a normal left ventricular geometry. Then we had a good proportion that had eccentric hypertrophy. And then finally, concentric hypertrophy or concentric remodeling, which was more frequent in male athletes. So if we look at this histogram, which shows the relationship with the type of exercise, static, dynamic, or mixed, we see that there are no big differences. We see that there is an absolute prevalence of normal LV geometry. But if we look closely, we see that endurance athletes, so athletes engaging in dynamic sport, females tend to adapt more often with eccentric hypertrophy. Very rarely concentric hypertrophy, concentric remodeling. Instead, in males, concentric hypertrophy, concentric remodeling is not uncommon, 15% of the cases. So if we want to summarize, we can say that females, especially the one engaged in endurance exercise, tend to develop very frequently eccentric hypertrophy, very rarely concentric hypertrophy or remodeling. Instead, in males, concentric hypertrophy and concentric remodeling is not uncommon. What are the possible explanations? I will say 3 hypotheses. The first, blood pressure. So we know that male athletes tend to have higher baseline blood pressure values. Also during exercise, males to develop higher values of blood pressure. Second hypothesis, hormonal differences, so testosterone, androgens versus estrogens. And we know, and these are data, especially from the heart failure world, that androgen receptors may mediate cardiac hypertrophy. Finally, the third hypothesis is performance-enhancing drugs. And it is possible that male athletes may use these drugs more frequently than female athletes. And we know that these drugs may mediate left ventricular hypertrophy also through hypertension. What about the electrocardiogram? We found some important differences out there. We know that Sokolov-Lyon criteria for LVH are frequently observed in athletes. However, they are frequently observed in male athletes, not so often in female athletes. Left axis deviation was more frequent in male athletes, and again, a QRS duration of more than 100 milliseconds was more common in male athletes. The last point that I want to discuss is the effect of gender on epidemiology of sudden cardiac death in athletes. And we know that there are striking differences in the epidemiology of sudden death in athletes between males and females. So males die suddenly much more frequently than females. So a ratio of 10:1, according to various studies. So why sudden death is more common in male athletes? We recently tried to investigate a large cohort of athletes, 357 athletes who died suddenly, and in all cases the postmortem was performed by Professor Mary Shepard, And in our cohort, we found 27 females and 330 males. So females were 8% of the cases. And we tried to look at the etiologies of sudden cardiac death, and we see that sudden arrhythmic death syndrome was the most common finding in these athletes, more common in females. Cardiomyopathies were more common in males. Very interestingly, idiopathic LVH, which basically means a heavy heart, a hypertrophied heart without myocyte disarray, was present only in male athletes. If we look at epidemiology of sudden death in non-athletes, however, we see that there are some significant differences. And males seems to be more affected than females also in these populations. So, possible causes. It's possible that male athletes tend to exert themselves to their limits more often than female athletes. It's possible that there is an hormonal effect that is protective for females and is deleterious for males. It's possible that male athletes tend to develop more frequently myocardial fibrosis, and we know this from MRI studies, and the studies are mainly on male athletes. It's possible, and we've seen that cardiac adaptation is different. So male athletes tend to develop more frequently concentric hypertrophy, concentric remodeling. Maybe that is the cause. Or maybe there are some genetic differences, maybe in the prevalence of cardiomyopathies or in the relationship between exercise and a pathological phenotype. So in conclusion, absolute cutoff values, if we consider just the absolute cutoff values, no female athletes have a LV wall thickness of more than 12 millimeters, and females rarely reveal significant LV enlargement. What about LV geometry? We said that is a parameter without dimension, so it can be very useful. Normal LV geometry is more frequently observed in athletes. Concentric hypertrophy or remodeling is not uncommon in males. Concentric hypertrophy and remodeling is very rare in females. Females adapt by developing eccentric hypertrophy more often. There are striking differences in sudden cardiac death, in epidemiology of sudden cardiac death between males and females with a ratio of 10:1. And we need definitely further studies to understand more about these differences. As it is possible that the different cardiac adaptation may explain, at least for some part, these differences in epidemiology. Thanks for your attention.